I'm happy to be here this morning to talk about some tips and tricks of fetal echo. So my lecture today is going to include the AIUM fetal echo updated guidelines that I spoke about yesterday, focusing a little bit more on the imaging component of those guidelines and what you need to be imaging and documenting, scanning techniques. And really the emphasis today is going to be on looking at the normal anatomy and documentation. So this is really kind of an attempt to put together a condensed breakdown of what you are required to be imaging in 2D, color Doppler, using pulse Doppler, and which components require measurements. So this is kind of a nice little breakdown to show you what components need to be looked at with each of these imaging tools. So this will be a part of your syllabus. So the start of my talk, I'm going to talk about evaluation of the ductus venosus. So I think the first thing to talk about with the ductus venosus is finding it. I think when people first start imaging the ductus, you need a really good technique to look for the ductus. And the best technique is really knowing its anatomic location. So it's located at the junction of the portal sinus just as it makes this L-shaped turn to the right. So pretty much at the level of your abdominal circumference, you're going to see the vein turning towards the right. Your ductus venosus is going to be originating at that point from the portal sinus and going straight back towards the spine. So this is where we'll see it. And let's talk about your color, because really I think most people, if not everyone, is using color Doppler in order to more easily and quickly pick up the ductus venosus, including myself. But the scale setting will definitely help you find it a little faster. So for evaluation of the ductus venosus, you want to be using a low velocity scale setting. And the reason for this is the ductus venosus narrows. It's about 1/3 of the diameter of the umbilical vein. So because it narrows, you'll have some aliased flow through that area. So here we see, here we have a higher scale setting, and basing off of finding the ductus by looking at for its anatomic location, we do see it here. But you can see when we turn down our color scale to the lower scale presets, now we can see it really pops out with that turbulence. And this is something that I use as well. So in this instance, aliasing can be helpful. It's not always a bad thing. And you can locate the ductus venosus either in the sagittal plane using the same technique that I showed you. In the sagittal plane, you would simply follow the umbilical vein in and you would see it narrow right at this point, and as it makes its track up to enter the IVC just closer towards the heart. So you can evaluate in sagittal or in transverse. Doppler is also required of the ductus venosus. This was not a change. This has been a part of the guidelines for a while now. So pulse wave Doppler within the ductus venosus, you're looking for continuous forward flow throughout the cardiac cycle, with abnormal being the A wave either approaching the baseline or going below the baseline. So let's talk about the axial planes of evaluation. So here's our 4-chamber all the way up into our 3-vessel trachea view. And of course I like to add in the abdominal view as well as part, basically just for the sake of completeness. And so one of the new requirements in the guidelines is to acquire a sweep. And basically what this is going to show us, if we start at the level of the stomach and sweep all the way up to the 3-vessel trachea view, we're documenting that the stomach and the heart are on the same side. We're even able to see crossing as well as the great vessels in one simple sweep. So we go all the way from the stomach and just keep sweeping up into the level of the 3-vessel trachea view. And really with this one sweep alone, you get a good sense of whether or not you're looking at a normal or an abnormal heart. So I think this is a really nice addition to the guidelines. Now looking at more details of our axial planes, let's start by looking at the 4-chamber view. So the 4-chamber view, again, needs to be documented with 2D color and cine. But I think it's also important to note that the 4-chamber view doesn't include just one plane. We can look at the 4-chamber view in an apical inclination. We can look at it more perpendicular to the septum with an axial plane, or we can look at it with the apex pointing away from us in the basal plane. So I like to image the 4-chamber view in not just one plane, in 2 planes. So I think even though we talk about it as one, I think the consensus is really you want to be looking at this 4-chamber view from more than one plane, and to document all the features that you need to, you do need to look at it in more than one plane. So, and the next step really with thinking about the 4-chamber view or doing your echo in general is to not get too tunnel vision too quickly. So when you sweep up to the chest and get into your 4-chamber view, you're doing a global assessment. Is the heart on the left side of the chest? Is the axis 45 degrees? Do the lungs look symmetric? Is the majority of the heart on the left side? So when I draw a line from the sternum through the spine, that should traverse the RV with about a third of the heart on the right side of the chest and 2/3 on the left. The heart should occupy about a third of the chest, and you should document if there's any evidence of pericardial or pleural effusions. So here's an example of a fetus that just has a trace pericardial effusion adjacent to the right ventricle. We can see it pretty clearly as this anechoic fluid-filled space. One of the things you might want to think about if you're not sure if it's a pericardial effusion is using color Doppler. When you turn on your color Doppler, we can see this anechoic space or the fluid fill with color. Because the fluid's adjacent to the heart, it's moving. So the motion is going to be detected with the color Doppler. So this is a way that you can confirm what you're looking at is a pericardial effusion. So this is one example where this might be helpful. So here's another fetus. This time we see a hypoechoic space along the left side of the heart. But this time when we turn on our color Doppler, the question is this a small effusion? I've got my scale set pretty low, and we see that that anechoic area is not lighting up. So what this is not a pericardial effusion. This is actually normal myocardium. So you don't want to be fooled by this. This is an easy, quick way to double check yourself. So 4-chamber view now documented with pulmonary veins. These are the basic components of the 4-chamber view that we've already talked about throughout this course, but I wanted to list them there just for the sake of completeness. So once I've finished looking at the global overall picture of the heart, I've noted the position, axis, size all look fine. I've noted that the tricuspid valve looks like it's slightly more apically offset than the mitral valve, and I can see a moderator band in my right-sided ventricle. The proportions all look pretty equal, and basically, in my mind, right is right and left is left in terms of morphology of the ventricles. So the next thing I'm going to do, I'm going to start to zoom in a little bit more and really look at these AV valves. I'm in a great angle of insonation coming in the apical 4-chamber view, and I just want to see them move open and move symmetrically. Now, one of the new components for 2019 was to now take measurements of both the mitral and tricuspid valve annulus in diastole, so when the valves are open. So remember, valves closed, systole, so this is not when you want to take your measurements. It's when the valves are open in diastole. And what you want to be looking for is the hinge points of the valve, and that's where you're going to put your calipers. So it helps to just scroll through your cine loop to identify this. You can kind of see a wisp of the valve leaflets here, but you want to place your calipers at those hinge points. So remember, Z-scores are not required. You want to, in our institution, as you can see here, when I measure the mitral and tricuspid valve annulus, I can put it in our calc package and it automatically reports a Z-score for me. So we do report Z-scores with the thought that we are already doing the measurements. We might as well report them with the Z-scores, but that is not required as part of the guidelines. So you want to compare right and left. They should be about equal in size, with the right-sided valve maybe being slightly larger than the left. So now that I've looked in 2D, I'm going to turn on the color as a supplement. I want the color flow to be smooth and laminar and going into the ventricles. My angle of inclination, I want to be parallel with the flow, right? I want an ideal Doppler angle. So this is what we have here, parallel to flow. I want normal laminar antegrade flow going into the ventricles with no regurgitation. And keep in mind, anytime I'm looking at a valve, as I mentioned in my optimization talk, I'm going to have a higher velocity scale. So somewhere in the range of 50 to 80 centimeters per second. This is set at 59. We'll get it you in about the right place. We also are required to be recording the valves or interrogating the valves, mind you, with pulse Doppler. So again, angle of inclination is ideally going to be in your apical four-chamber view because you're coming in parallel with the flow. So you want to place your Doppler gate just distal to the AV valve within the ventricle. You're going to go ahead and pulse both of these valves and record the waveform below. So your E waves representing your early phase of diastole or the passive filling, and the A wave is representing that atrial kick or late diastole. So your E wave should be smaller than your A wave on your waveform. Next, we're still studying the features of the four-chamber view, so I'm going to be looking for the pulmonary veins. So we want to see them in 2D, we need to look at them with color, and we need to Doppler them as well. So this can be done from looking at the four-chamber view in various planes. Apical or subcostal will work. You want to visualize at least two of them, one right-sided and one left-sided, to help you rule out any significant anomalous pulmonary venous return. So this is showing coming in from more of an axial plane, and I really like to look at the pulmonary veins from this view, especially with color and Doppler, because if we look at my angle of inclination, you can see I'm coming in parallel to flow with both a right-sided and a left-sided vein. So from this perspective, I can show my color very nicely and easily, and I can add pulse wave Doppler to obtain and confirm that these are pulmonary veins entering into the left atrium. So in my experience, I really find that the 2D features of looking at the pulmonary veins have been most helpful for me to pick up abnormalities. I think the color and the Doppler are really good adjuncts, but for me, the 2D is the key. So I'm always really focused on looking at the left atrium in this area behind the heart. So when you're looking at the left atrium, keep in mind it shouldn't appear bald or small. The pulmonary veins should be going into it and may make indentations. there should be a small space in between the left atrium and the descending aorta. There should be no room for any confluence or what they've called a twig sign back there where your pulmonary veins might be draining into. And as I mentioned, pulse wave Doppler is required now also, one right and one left-sided vein. And again, this just confirms that number one, you are seeing a pulmonary vein and you're not looking at a different vessel, such as one of the pulmonary arteries. And number two, that the flow looks normal, that you don't see any signs of obstruction that could lead you to think that there could be anomalous pulmonary venous return. So these are some examples I think that are helpful from this paper that was published in JUM in 2014 by Gannison et al. That just shows you some different examples of abnormal pulmonary venous flow. In their paper, every fetus that had TAPVR, no matter whether it was obstructed or not, had an abnormal pulmonary venous waveform. You want to be looking at the patent foramen ovale. You can look at it from the four-chamber view. You can also look at it in the long axis planes when you're looking at the bicaval view or aortic arch views as well. And do need to scan at a little bit of an angle, so this is not ideal for an apical insonation, but here I'm coming in at about 45 degrees. I can see in 2D my foramen ovale flap coming over towards the left and then confirming with color. So important with the color for the foramen ovale, in my experience, to really optimize. So you want to have your color box small and color scale low to see that flow going in to the left atrium. Septum, we want to assess in four-chamber view as well as short axis views. So you're going to want to, in this instance, definitely not look at this in the apical four-chamber view. You're going to want to be assessing it perpendicular to the beam. So now we're optimizing our 2D here by coming in perpendicular, and then also our color flow as well, because when we look with our color flow, if there is a defect in between the septum, the flow direction, I'm insonating more parallel with the beam, so we're going to pick that up easier. You're going to want to turn your color scale low, so somewhere in the range of about 30 centimeters per second is going to get you in about the right place, and this is because we know that both the pressures on the left and right-sided ventricles are about the same. So you're not going to be getting a high velocity shunt if you have a VSD in an otherwise structurally normal heart. You have to turn the scale down to pick this up. So here's an example of how not to look at the septum. Again, as I mentioned, you don't want to be looking at it in the apical four-chamber view. And one of the main reasons behind this is we are coming in parallel with the septum, but also the septum tends to taper off as it gets closer towards the crux of the heart or get thinner. So it is an area that's more susceptible to dropout, and I think all of us here who scan know this. So what you want to do when you see this potential area of dropout is you want to just adjust your angle of insonation or reposition your probe to come in more perpendicular, or at least at an angle. It doesn't have to be perfectly perpendicular to the beam. And now we can see that this area underneath the AV valves looks intact with 2D. And same goes with color Doppler. There's been several times where a sonographer or a physician might be wondering if there could be something going on here because they're seeing this overlapping of color flow into the right and left across the right and left ventricle. But this is what we call fluffy color. This is consistent with color bleed, and we're also coming in at an apical insonation more parallel with the flow. We want to be looking at this septum in a more perpendicular way. So this is really poor technique. We're coming in parallel to the septum. This is color bleed, or what we call fluffy color. This is the way we want to be coming in. Again, it doesn't need to be perfectly perpendicular, but it should be at an angle. So a real VSD is, when we look at the septum, is going to be consistent and reproducible. When you're looking, you see it in the same spot, and often the color flow direction is bidirectional, because remember I mentioned that pressures on both the right and left sides are close to equal. So you expect your shunt to be both blue and red, going both directional, so bidirectional shunt. So this is an example of a true VSD. So next, let's move into our left outflow tract plane. Okay, so left outflow tract needs to be documented with 2D color and cine clip as well. And things to look for in this plane, as you're looking at the left outflow tract, make sure that the left ventricle gives rise to the aorta. Sounds simple enough, but not always. You're going to be looking at the continuity of the ventricular septum with this anterior aortic wall to make sure that there's no override or large VSD there. You want to make sure that you're looking at the valve, you want to pay attention to it, you want to see it, you want to make sure it's thin and moves freely and comes and goes throughout the cardiac cycle. And now new with our guidelines, we're also going to be measuring the annulus. So you'll want to measure the annulus in systole with the valve open. And when you scroll through, we can watch it and see where these hinge points are and know where to put our calipers. So again, aortic valve annulus needs to be reported. Z-score does not need to be reported. And as I already mentioned, we're doing that in our lab. Next, we want to look at color flow. So you see there's a pattern here. I'm looking at 2D first, then I'm putting on color, and then I'm putting on my pulse wave. So color flow, optimize your Doppler angle. The color flow should be laminar. I like to see it actually cross the valve and make sure that I don't see any sign of regurgitation. And when I Doppler it, you can see in my image up here, I've come at a little bit more of an apical inclination to try and optimize my Doppler angle. But I'm placing that Doppler gate just distal to the valve in order to obtain my waveform and measuring peak systolic velocity. Your right ventricular outflow tract. Okay, so again, 2D color and cine. And looking at our 2D first, we're looking to make sure that we look at the pulmonary artery and the aorta from this view. They should be about the same size, with the PA maybe being a little bit larger. Your main pulmonary artery should branch. That's how into the right and left pulmonary arteries. And the pulmonary valve leaflet should be thin and mobile, with addition of now measuring the pulmonic valve annulus at the hinge points. So again, pause, use your cine to scroll back and forth to see it, and then you go ahead and place your calipers and make the measurement. Color and pulse waves, so again in the same sequence, doing my 2D first, then my color, and then confirming with pulse wave. Optimizing my Doppler angle parallel to flow, and same thing, color flow should be laminar, there should be no regurgitation, and place that Doppler gate just distal to the pulmonic valve to obtain your waveform and measure the peak systolic velocity. And it's always nice, in addition to obtaining just the sweep that we did from the stomach up to the 3-vessel trachea view, is to take a dedicated sweep, looking at the crossing of the great vessels, making sure that they cross at the level of the valve. And this axial inclination is a really nice place to do that, because we can also look at both valves as we do that too. And we can see it, aorta and then pulmonary artery. And then when you use your color Doppler, the vessels are crossing each other, one going towards the aorta, going towards the transducer, and this particular position and the pulmonary artery going away from us, so they're different colors, so it makes it a little bit easier and demonstrate on your clips. Now moving into the 3-vessel views. So 3-vessel view, a lot of people ask how to obtain it. Really the easiest way is going from that 4-chamber view and just sweeping straight up towards the baby's head. You'll run right into the 3-vessel and 3-vessel trachea view as you make those tiny little millimeter moves up towards the head and neck. So within the fetal echo guidelines, the 3-vessel view is now broken up into 3 planes instead of 2. So the 3-vessel view is now taken at the level of the pulmonary artery bifurcation as well as the level of the ductal arch. Both of these planes, which are within millimeter of each other, show that the ascending aorta is in cross section, and of course the SVC being in that plane as well as the most posterior and rightward and smallest vessel. And then of course the 3-vessel trachea view, which shows our arches in long view and make that V configuration to the left of the trachea. So this is showing a very simple sweep, just showing how close these are. So remember, the pulmonary artery bifurcation is your most inferior plane, followed by your ductal arch, and you see just very tiny movement. Typically, we only see the right pulmonary artery easily. The left pulmonary artery is often obscured by the ductal arch, which overlies it. So it just takes a very tiny sweep inferiorly in order to pick this up and see this LPA tapering off to the left lung. That way you're ensuring that the branch pulmonary arteries are confluent. 3-vessel trachea view, as I already mentioned, shows both arches in long, so we're catching both the ductal and the aortic arch. And then when we turn on our color flow, it's going to emphasize showing us this nice normal V configuration. Vessels going both towards the descending aorta and again going to the left of the trachea, defining them as both a left and right a left ductal arch and a left aortic arch. And to keep in mind for your color flow, both of these vessels should be going towards the spine, towards the descending aorta. So of course, depending on how your fetus is laying, the color flows may be different. So here we see if the spine is at the 4 or the 8 o'clock position, you may get different colors in your vessels. But that still can be normal, and that's why it's important to remember the physics of ultrasound when we're looking at this. So if we look at our aorta, it's coming towards the transducer, so it's appropriately coded red. But our pulmonary artery and our ductus are still situated going away from the transducer, but they're going towards the descending aorta. So it's important to remember that all of these configurations, whether the spine is down, spine is up, you have the same color in the vessels, or if the spine is situated, like I said, about the 8 o'clock or the 4 o'clock position, you may see this configuration, but all of these are normal. So now we'll move into the short and long axis planes. So into our high short axis view, our low short axis view, and our long axis view, very similar to our LVOT view that we looked at. So starting with the short axis view, so just think of just traversing through this mitral and tricuspid valve and looking at them in cross section. So we can see both our mitral and tricuspid valve in this plane. So we want to be documenting this in 2D, cine loop. I do on all of my heart views, but for the guidelines, it's only if clinically relevant. You want to see that you have your mitral valve and your tricuspid valve, and we've noticed our mitral valve, we can see it moving. We see it does not have any association with the septum. Whereas the tricuspid valve, this is what distinguishes it, does have a septal attachment, so it's much more closely related. So this is another great plane to look at them and also to appreciate that difference in the anatomy. You want to be sweeping through the short axis view. This is another really good way to look at the septum. So you want to go through the short axis view all the way. I go all the way through the apex till I'm out of the heart, and then sweep all the way up to the outflow tracts to make sure I've interrogated the entire septum, with, again, keeping my velocity scale low. This is another place where the short axis view might help you. I'm just going to show you the 4-chamber views first to get you acclimated. This is a normal 4-chamber on the left side, and then on the right side we have an atrial ventricular septal defect we can see with just a single valve coming across, going into both ventricles. If we look at these hearts in the transverse or in the short axis plane, this is a really nice way to look at that single AV valve and prove that it is a single AV valve. So when we look here, we can see really nicely that we have a common atrioventricular valve as opposed to our normal 2 valve. So this is an essential view in context of looking at these valves. Now moving into our long axis planes. So we have our bicaval view, our aortic arch view, our ductal arch view. So first going with our aortic arch view, again looking at it with 2D color as well as using a cine clip. I've included this slide for you just to point out the anatomy that we see in this plane for sonographers or physicians who are taking the ARDMS fetal echo boards. It's really important to know your anatomy, so I'm going to leave that for you there. Looking at the aortic arch arises from the middle of the heart. It has this candy cane appearance. And when we look at it with color flow, the color flow should be prograde, smooth, and laminar. We also want to be paying attention to the head and neck vessels. You want to be looking for this as you go back and forth. You might not be able to see all of them on every fetus, but you want to be paying attention to this because this is how you're going to know that you're actually on the aortic arch and you're not overlapping with the ductal arch, which is in very close proximity. Now looking at our ductal arch, so it arises more anteriorly from the right ventricle. It has this described as more of a hockey-shaped type appearance, and it connects to the descending aorta. So when you're looking at the ductal arch, you want to make sure that you're imaging from the level of the pulmonary valve all the way to the descending aorta. And we can see that we're coming actually more on top of the heart. You can see the difference as you traverse through the 4-chamber view. It's a little bit more anterior than the aortic arch plane. And looking at the color flow, again, watching it go from the pulmonary artery all the way to the descending aorta, confirming that it's normal right to left flow. Into your bicaval view, looking at this with 2D color and with cine. So this is another long axis plane. We also are looking at this with color Doppler as well. This helps us assess the presence and direction of flow as well as confirm vessel proportions. They should be about equal in size. When I look at the bicaval view, I do like to use my more highly sensitive directional independent color flow because I am coming in pretty well perpendicular with both of these vessels. I need more highly sensitive flow in order to be able to pick this up. And as I mentioned, this is another place where we can also look at the foraminal valley flow. So we can see really nicely here how it's going from right to left and track it into that left atrium. So this is a really nice plane, especially if you're worried about it. I would definitely be looking in this plane as well. And finally, looking at your heart rate and rhythm, we need to be looking at atrial and ventricular rates. Of course, we're assessing function. You can do that qualitatively throughout your scan. But I want to talk about doing an M mode. Because when you take your M mode, it's important to optimize your M mode as well so that you can see and distinguish both the atrial and ventricular rates. So if you are scanning the heart and you've got a pretty good image, but you just overall zoomed it up and put your M mode tracing down, you're not going to get a very good tracing. And the reason is the M mode, even when you overall zoom, is reading everything in your image. So it's taking everything as it traverses anteriorly through the heart and posteriorly, and it's reading that on your M mode. So in order to optimize your M mode, you want to tell the system to only look at what you're wanting it to. So by that, you use the right or the zoom box. So you want to place your zoom box over the heart, and by that, it's only going to read what's within the box. Zoom it up, and now we put our M mode cursor in, and now we can see, we can much more clearly differentiate the atrial and ventricular points on this M mode. So that's a really good way to take an M mode. So that's the end of my lecture today. I think take-home points I wanted to talk about is to really practice a systematic evaluation, of course, to remember the sequential approach, but also, as I mentioned, focusing on doing your 2D first, then color, then pulse wave is a really good strategy to make sure that you're looking at everything in a systematic fashion. And I always prioritize 2D first. I want to make sure I see everything well in 2D. I use color and pulse as my supplements. Optimize your image, as I talked about yesterday. You all know how to do it. I can't emphasize enough how important it is. Image quality, image quality, image quality. Your angle of inclination, as I mentioned, it needs to be more perpendicular, looking at 2D, but you want to be parallel to flow with your color and pulse wave Doppler. Adjust your color scale, again, high for valves and vessels, which is going to be at that 50 to 80 centimeters per second, and low for venous flow, looking at the septum, foramen ovale, and the ductus venosus. So thank you very much for your attention.